Hello, Dr. Pelto here. I want to go over a little bit about diabetic foot complications. This is a lecture that I'll be giving to the endocrinologist residents or fellows at Umass Medical Center. Let's get right into it. What I want to share today are some of the current treatments and some of the advanced therapies when you're treating diabetic feet. So first of all, we want to look at some of the learning objectives here. We want to diagnose what an at-risk foot is, determine the risk factors leading to diabetic foot infections and ulcers, what's the current treatments for diabetic foot ulcers, and then understand the incidence and the economic impact on diabetic foot infections. First, I want to show you some of the at-risk diabetic feet that we see in our office. A lot of times these examples, real-life examples, are easier to see when you're seeing your patients to evaluate what you're looking for. So you see here this picture on the left here. This is a pre-ulcerative wound. You can see the skin is broken down, this callus, there's a little bit of blood underneath there. This is a high-risk foot. And the difference between this foot and this foot is this patient has already lost the big toe. And what you can see is there has been a change in the way the pressure is applied, and there's more pressure to that joint, to that metatarsal head underneath that area, because all this bone has been removed. Usually the toe is able to take some of the weight when someone's walking, but in this case they can't. This is just waiting to open up. The best way of treating this is frequent care of trimming of that callus or that pre-ulcerative lesion, and then either custom orthotics or diabetic shoes can be helpful to take the pressure off of that area. Here's another example at the tips of the toes. You can see this patient here, this image on the left, these two calluses that are at the tips of the toes, and this callus right here. These are caused by the hammer toes, and once again, in the same manner, if these aren't trimmed down every so often, they are going to ulcerate for this patient. The best type of treatment for this is frequent trimming of these calluses, making sure the shoes are appropriate size, diabetic insoles, and maybe even straightening out those toes. Another example here on the heel region, this patient had a previous ulcer on the heel, and you can see the scar tissue right here. This is just waiting to break down. This patient is actually seen once a month. Normally insurance covers every 9 weeks, but because of the buildup on this ulcer, if this isn't treated every 4 weeks, it's going to ulcerate. Same thing you can see here. This is a compression stocking, and you can see on that third toe, there's a pre-ulcerative lesion. This as well, it was a patient that wore a shoe that was a little too tight, and they didn't notice it because of their neuropathy, and it caused an ulcer that is healing up. An ulcer on the front of the leg as well. This is a very common problem with our diabetic patients. They hit the front of their leg on an object or on a table, they get a cut, and then that can develop cellulitis. You can see the area is marked. So anytime you see an area of redness on the lower leg or on the foot, it's good to mark it, put the date, and take a picture of it so you can see if there is progression or resolution of that cellulitis. Another high-risk foot, you can see it's high risk because this patient, you can see the image on the right, they've had a previous incision here for an interspace infection, and this is a very hard to deal with ulcer right here. They don't have as much fat pad down here. And you can see this patient as well, they have lost part of their foot, and that makes it a little bit more challenging, and they have all of this callus buildup. You can see the toe caps that we placed on the toes to help avoid any rubbing. Sometimes it's kind of an act of gymnastics of trying one toe cap or one spacer or one shoe or one orthotic, and it can be very challenging for us. That's why there's very limited risk, limited room for error for these patients. What we see is that if all these precautions aren't taken, and if something happens, it can very easily develop into an ulcer and develop into an infection and can lead to an amputation. I want to go over the most common risk factors for diabetics, and this is an exam that we all can do, that most primary cares and endocrinologists may do in some portion of it. But I want to look at what is a comprehensive diabetic foot exam. All patients, whether they have severe symptoms or not, should be seen yearly by a podiatrist for a comprehensive diabetic foot exam. There's even a lot of insurance companies now that are requiring, they have some paperwork that patients have to fill out. And then based on these results, they may or may not be seen more frequently. We're going to look at the skin considerations, the nerve and neuropathy considerations, the bone considerations, like the structure of the foot, vascular considerations, and then shoe gear. We can't forget the importance of shoe gear. A lot of my job is advocating towards proper shoe gear. Let's first look at the skin. Dry skin can be a problem with our diabetics because they can have autonomic neuropathy. So along with sensory neuropathy, they also have autonomic, and that affects the sweat glands. And many times they can get dry skin, makes them more prone to fungal infections, heel cracking. And here's an example of a heel crack or a heel ulcer that opened up that was very hard to heal for this patient. Fungal infections are also important for our patients. We saw one of the patients previously that developed a fungal infection or dampness between the toes, and then that can develop and get a cut in the skin and create a cellulitis that needs to be surgically debrided and opened up to get rid of any pus that's in there. So being very careful of a fungal infection for our patients is important. Calluses are very important because calluses are always precursors of ulcers. Areas of callusing are usually the areas that will develop an ulcer in a neuropathic patient. You have to treat these calluses. I don't recommend patients taking their own razor blade and trimming them down. I recommend them seeing someone. Nail salons don't do this anymore. They have a little buffing pad, but once again, even with these buffing pads are like almost like a metallic buffer. You have to be careful with neuropathic patients because they're not going to feel that, and that could develop into an ulcer. Many times we do see that. So calluses need to be treated. You have to determine what's a callus and what's a wart. Many times it can be misdiagnosed, especially this lesion here on the left. It's a little circular lesion. People many times mistake this for a wart, but this is something called a porokeratoma. Basically, it's the pore, the sweat gland has a very focal lesion that gets very big and can become painful for our patients. There's a couple of ways of offloading this in the shoe or in an orthotic, but basically this is caused because of focal pressure on one area, kind of like a magnifying glass, how there's focal power of the sun coming down to a focal area from a magnifying glass. All of that pressure goes underneath that metatarsal head in that area. Also, interdigital lesions, one problem would be athlete's foot. Another thing is the rubbing of the toes. You can see here marked out the toes, the proximal and distal phalanx on this toe, and there is tends to be a rubbing. This area rubs right against this area, creates a big callus in there. That can be problematic. There is a surgery that can be done where you take out this proximal phalanx head, and that reduces the rubbing between there. These can be trimmed down. They do happen quite frequently, and they could ulcerate, and that's the problem. Another type of a treatment that sometimes can be done is where you sew the toes together. Basically, you draw with a marker right here, you push the toes together, and you take out that skin, and then you just sew the tops here, this side to this side, and the bottom to the bottom. That's another type of a treatment for these interdigital lesions. These can be very problematic. They're made worse if someone's wearing a shoe that's too tight. Ingrown toenail, this is a big problem for our patients. There's a couple of type of procedures that can be done. One is a simple trimming of the nail, and that's done every 2 or 3 months. If it becomes chronic or keeps coming back, or they're trimming their own, the old-fashioned way has been to just numb the toe up, take a little portion out. You can see right here, this portion is out, and let the nail grow back. If the nail keeps on growing back ingrown and causing this swelling on the side and infection, then there's a procedure right here. You can see there's a Q-tip that we place in the base that can either be done with phenol or sodium hydroxide. In our case, we use sodium hydroxide, and that's going to kill the nail matrix so that nail won't grow back. But for some patients, they don't like this narrow nail look. Basically what happens is sometimes it looks like a little diving board because you take out both sides and then it resolves the problem, but it looks like a funny looking nail. There is a new treatment called OniFix, and it's basically a white resin that is applied on the top of the toe with an epoxy so that it won't fall off, usually for 3 to 4 months. This is applied, it's totally safe. There's the only complications that it could fall off, but it actually trains the nail as it grows out to grow out in a straighter format. You can see here, this has been applied to this patient right here, and you let it grow out, and then it will help reduce that pressure in the nail edge. This is a newer type of a treatment. Usually needs 3 applications. They're done about every 3 months. So as the patient comes back for their nail care, we do that application. Those are some treatments for ingrown toenails. Ulcerations, there's a lot of different types of ulcers. This is an example of a midfoot breakdown with a Charcot foot where it's been debrided. And this is, you try to get this healed. This patient is placed in a crow boot, which is a big, almost like a walking boot, but it's custom made to offload that area in the middle of the foot until that's healed. If it keeps breaking down, then there's different types of Charcot surgeries that are needed. This is an example of a patient with an infection, very long-standing ulcer that was very difficult to heal. These tend to be very challenging to heal because patients don't feel them. So they are neuropathic and they keep walking on them. Keeping our patients off of their feet is quite a challenge for many of us. And that's the biggest kind of complication when dealing with ulcers and avoiding infection and having them come back. Next, we're going to look at the neuropathy considerations. This is something that all endocrinologists and primary cares do. You feel different areas. A few little tips for this. I recommend patients close their eyes because many times they want to please us and they say, oh yeah, I can feel that, or I can feel that. So I just say, please tell me every time you're feeling it, just say yes, or say some type of a word. And they need to feel at these primary sites underneath the big toe, first, third, and fifth metatarsal heads. And then I tend to do all the toes, or at least first, third, and fifth toes, and then some other areas on the heel and on the top of the foot. If they can feel those on both feet, they are very low risk for developing a diabetic ulceration or having a problem healing a wound because they can feel that. As well, there's a tuning fork test that can also be done right here. You can see the tuning fork that's used to evaluate the vibration on the toe. And if they can feel this, this can help the patients out for having any other problems. What we tend to find is that the tuning fork test tends to be positive before this test of the Sims-Weinstein. And you have to have the patient evaluate when the vibration stops. Next, let's look at some musculoskeletal considerations for foot deformities. We showed a few of these pictures before, but these toes here, these are caused by hammer toes. This is caused by a hammer toe, another hammer toe, a bunion. All these foot problems, they don't need to be fixed unless they cause an ulcer or cause a problem. A lot of our patients just need proper shoe gear to not have these be a problem. But if they continue to open up and become ulcerations, then you need to consider some type of a foot surgery for this. Just because someone's diabetic does not mean they can't have foot surgery, but you really should be careful that their A1C is under control if you are doing that to prevent any risks of infection or slow healing. Let's look at some of the other foot deformities. The one I want to focus on most here isn't so much the bunions and hammer toes, but it's basically a Charcot foot. A Charcot foot is where there is a collapse, usually in the midfoot. And this is very commonly mistaken for an infection or a cellulitis, but it tends to be a red hot swollen foot. It's very important to keep a patient off of their foot if they have something like this and do some type of offloading of their foot, probably for 6 months up to a year with serial x-rays, usually once a month. And this is something that's very commonly mistaken. I've seen 2 or 3 during this COVID period time. And it's very hard because you have to keep people totally off of their foot. And they don't have feeling, and so they don't know there's a problem. Very commonly, patients are admitted to the hospital for cellulitis. They get antibiotics. The redness goes down, not because of the antibiotics, but because they are off their foot. And then when they start walking around on it again, it gives them a problem. So the best type of treatment for this would be one of those crow boots. That's a Charcot restraining orthotic walker type of a boot. You can see it here, kind of a red hot swollen foot. If that's not treated, it'll continue to break down and develop an ulceration. This is an example of that crow boot. And then we keep them totally off of their foot as well. This is going to be a period of about 6 months of non-weight bearing, and then they can be transitioned to a patellar tendon bearing brace. That's another example of a brace. All these can be done at a local podorthist. Some of the circulatory considerations as well. Once again, Charcot, what I mean by that is if there is Charcot, it tends to be a red hot swollen foot. There's usually not a circulatory problem, but with excess circulation, sometimes they say in the research, it could be one of the theories is that all the increased blood flow to the area, all the blood vessels kind of open up and they vasodilate and causing a weakening or a softening of the bone, causing that Charcot. It's very important to do Dopplers in our patients in the office if we can't feel their pulses, and then ABIs and PVRs. We tend to do that once a year for our patients that have diabetes over the age of 50 and non-diabetics over the age of 70. And then if we see any changes from year to year in the ABIs, we'll send them for further vascular exams, usually through vascular or interventional radiology for an MRA to evaluate if there's any problems. The technology is so now with these endovascular procedures that they can help with healing of ulcers at the tips of the toes. Sometimes they can go, we call retrograde. They can go through the toe region and then up, opening up these vessels. There is a lot of new research and procedures that can be done by the vascular surgeons that are trained with this endovascular procedures. Then we want to go over some shoe gear considerations. I want to really focus on this picture. This is really important. When you have a patient and you should have them take their shoes off. You should make sure the shoes are wide enough. The best way to do that is take the sock liner out. This is the sock liner is this thing right here. Pull it out of the shoe and have them stand on it. If their toes are going over the side, because you could see if this patient stood on this type of a liner, the toes would go over the side here. This is way too narrow. This is going to cause callousing. It's going to cause hammer toes, cause bunions, cause a lot of problems over time. So you have to make sure that the shoe is wide enough. And when I talk about wide, I don't like a totally wide shoe throughout. I tend to like what we call an anatomic shoe. That would be more wide in the front and normal in the back. You have to make sure it fits. You want to do about two finger breadths in front here. Make sure they're not worn out. See if there's any insoles. Sometimes patients, they tend to add insole after insole in there, and then there's not enough room because they're adding 2 or 3 insoles in there. And then making sure that they have diabetic socks or compression stockings. Some of them need compression stockings, but you have to be careful with the shoe gear. I find shoe gear is the main conversation topic and one of the main causes for ulcerations, because patients wear good shoes all the time and then they may go to an event like a wedding or a graduation and they're wearing a fashionable shoe that just causes ulcers or problems. Also, when people go from season to season, I find there's a lot of ulcers because shoes tend to stretch out, leather shoes specifically as you wear them. And then if you go a whole season without wearing them, the leather gets tight. And patients with neuropathy, they can't feel that. And so they break, they develop blisters or ulcers because of that. Here's a couple of examples of patients that wore shoes that developed blisters. Just want to explain. This patient was already missing some toes and they only had one toe here, and this caused a blister. Another blister caused by a tight shoe here. Another one by a tight shoe, rubbing right here, more rubbing in these blisters. So let's go over now diabetic foot ulcers. This is one of the most common complications of people with diabetes, our patients. The annual incidence is 1 to 4%. So all of our diabetic patients, 1 to 4% are going to have an ulcer. And this is very, very common. And sometimes these are little pre-ulcerative lesions, like a callus with a blister. The lifetime risk, though, is 15 to 25%. So about 1 in 4 of our patients, they are going to get ulcers, and we need to be aware of them and need to prevent them. The problem is that 15% of the ulcers result in a lower extremity amputation. And this is a big problem. Even if they're treated, they can lead to an amputation. Then 85% of lower limb amputations in patients with diabetes are preceded by ulceration. So basically all of the amputations in diabetics are preceded by an ulcer. That's why ulcers are so important for us to evaluate and for us to treat. And peripheral neuropathy is the major contributing factor in diabetic foot ulcers. So even more so than peripheral arterial disease or poor circulation is the neuropathy. So the neuropathy we need to be aware of. We have to diagnose it. We have to try to prevent it as much as we can and be aware that along with poor shoe choice could cause a great problem for our patients. The cost to treat a diabetic foot ulcer, here you can see it's just a very expensive proposition here. Over a 2-year period, the diabetic ulceration, being debrided in the office, being come back for additional exams and things like that. It's very expensive, upwards of $45,000, and that was in 2008, and now this is many years after, and so the price just keeps going up. One thing you have to be aware of is that the 5-year mortality rate for people with neuropathic ulcers is about a 45% 5-year mortality rate. And we have to tell our patients that because sometimes they don't understand the importance of an ulcer. And I'm not saying that they're dying from the ulcer. They might have other comorbidities or other problems on top of that. So there's a high mortality rate because a lot of times these patients are very unhealthy to begin with. Diabetes out of control, other heart problems, and they may not be able to live longer because of these ulcerations. The recommendations, you may want to know what you should do. Basically, it's very simple for a referring doctor, or primary care or endocrinologist. They should get a yearly comprehensive diabetic foot exam by a podiatrist. This is something easy, whether or not they have any symptoms or not, or complications or not, just a yearly exam. When should you start that? If someone has type 1 diabetes, they could even start it earlier as a child just to develop that relationship, kind of like going to the dentist. But then as they get a little bit older, you're going to want them to go see the podiatrist. There's a lot of young people that had diabetes that's out of control, developing neuropathy and amputations at a young age because they haven't had appropriate evaluation, both of their lower extremities, also their eyes, and other areas that can be affected. Yearly diabetic footwear with insert changes every 4 months. Patients can qualify for 3 pairs of inserts. There's a couple of local stores that do these in the community. It's getting to be a little bit more challenging to find someone that does a good job. There's both custom insoles and non-custom insoles. The non-custom ones, basically you take the liner and you put it in a little heater oven, and you heat them up and have patients stand on it, and then it forms or molds to their foot. There are the custom ones that are kind of like a custom-made orthotic to offload areas of high pressure. So those areas that we showed you before that had callusing and had little blisters or pre-ulcerative lesions, they can be offloaded to take pressure off that. And then every 2 to 3 months, routine care based on symptoms. Not everyone can qualify for what we call routine care. It really should be high-risk care, but basically trimming of nails and calluses in the office by a podiatrist can be done every 61 days for people that have diabetes plus something else. We'll talk about that in a little bit. And then a daily foot evaluation by the patient or a family member is very important to see if there's any problems, and then following up with an appropriate provider. This is always a good question that we get. Who qualifies for diabetic callus and nail care? Can just anyone come in if they have diabetes and get nail care? Not really. It basically is reserved for people that have high risk factors. You have to have diabetes plus something else. So that would be peripheral arterial disease or some other type of neuropathy. Basically, poor circulation or neuropathy are the main reasons. It's not because you have other things. If you've had an amputation, yes, that qualifies. If you've had, other things, and you just have to see the podiatrist. And usually, what we do is we send a form to the doctor that you have to fill out just to verify that they have some of these things that are going on. We can kind of work together, any things that we're missing, but not just anyone can come in. If they have normal nails, usually a fungal toenail, like a thickened toenail, is covered. But let's say they have thin toenails and a callus, not always covered just because they're diabetic, okay, because they're not high risk. Who qualifies for diabetic shoes? Basically, a patient has to have diabetes and one or more of the following. They have to have a history of a previous amputation, history of a previous ulcer, a pre-ulcerative callus, peripheral neuropathy, which is a lot of our patients, and then a foot deformity or poor circulation. So most of our patients do qualify for shoes. If you feel their pulses and they're missing, you can't feel a pulse due to swelling or something, that would qualify. If they have a foot deformity, which would be a hammer toe, a bunion, a prominent metatarsal, anything like that, that would qualify. Neuropathy, a lot of our patients have some amount of neuropathy. I was asked to provide a couple of board questions for those that are here, just some questions that'll help you with some of the future questions here. So what are the major risk factors for developing a diabetic ulcer? The risk factors are these: previous amputation, history of ulcer, pre-ulcerative calluses, neuropathy, foot deformity, or poor circulation. These are some of the really high risk factors that can be problematic. These are the same ones that qualify for diabetic shoes. What percentage of diabetics will develop a foot ulcer in their lifetime? 15 to 25% of patients in their lifetime will get an ulcer. How do you do a comprehensive diabetic foot exam? Basically, it's just evaluating the skin, the nerves or neuropathy, the bones, any vascular considerations, and then shoe considerations. These are all real important for a diabetic foot exam. This should be done once a year. You can do it yourself. You can send it to a specialist, but it should be documented in the chart. What is important when treating diabetic foot ulcers? the real four tenets of treating ulcers are circulation, making sure there's proper circulation, making sure there's no infection, debriding of the ulcer, and then offloading of the ulcer. If a patient has good circulation, if there's no infection, and if you can debride that ulcer, then usually the big problem and really the main issue for most of our patients is offloading, staying off the foot. If we can stay off the foot, we can get the ulcers to heal. And that's even more important than what you put on the ulcer in terms of what types of dressing. It's more important to stay off the foot. There's a couple of patient resources I'll give you access to, and a couple of books that I recommend for my patients that can be found on my blog. Heal Your Foot Wound Fast, just a kind of a little review of healing foot wounds, and then a healthcare guide to diabetes in your feet. This is what I give for all my patients that are diabetic. I just send it out once a year. I have it kind of in a video format in case people don't like to read. But I think the more we can provide our patients these resources to help heal ulcers or prevent problems, I think that's key. Once again, thank you for your time. I'm going to put more information under the description of this video with some of these resources. Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.